You can't be abolished. I tell you why you can't be abolished for what you're already doing. Because of precedent. You've been using fluorescein here for decades. They can't take your parnassa away from you for doing contact lenses, for example. You know? So that's precedent. I agree with you though. You still need to have a change in law, I think. Although I understand that many optometrists here do use diagnostic drugs quietly. So I was saying, we've been using an OCT, an optical coherence tomography, in my practice for at least 5 years now. And it's a very exciting technique. I'm going to deal with what is it, what is an OCT, its importance for glaucoma, and its importance in retinal diagnosis. What is it? It's a non-contact technique for high-resolution cross-sectional optical imaging of the ocular structures. It's like ultrasound. The first time I saw, when the OCT came into my practice, and I had no knowledge of it, and I saw the images, I thought, this looks like ultrasound, because I used to do ultrasound years ago. Except that the OCT measures the delay and intensity of back-reflected infrared light rather than acoustic waves. The velocity, of course, of the light is very high, so direct measurement of optical echoes cannot be made electronically like you can in ultrasound. The technique to measure the back-reflected light time delay is based on Michelson interferometry. So what does it do? It allows a cross-sectional view through a structure. You can image what previously could only be seen on a histology slide, an eye that was removed from someone who's dead or had some problem with the eye, and then take sections through that eye. But this gives cross-sections in a living patient, and the technology that it uses is used in other disciplines. It's used in radiology, and it's used in art conservation. So if they think that the Rembrandt painting is painted on top of another Rembrandt painting, they use the same canvas, you can use this to look through the image. Optical means light, coherence is the type of beam, and tomography. Tomography means slice, like a slice of cake, as opposed to topography, which is the shape. So OCT is a slice of the eye using a controlled beam of light. How does it work? The tissue is irradiated by the light, and each tissue type has a different reactivity. The returned signals, the echoes, are coloured by the software according to how reflective the tissue is. Some wavelengths of light penetrate deeper into the tissue, into the retina, than others. So blue doesn't penetrate very far. White light goes right down to the choroid capillars. There's green, and red goes through the choroid. So using different wavelengths, you can actually view different structures. We're looking at a cube. If we take a cube, the A scan is front to back. These are axial depth scans. B scans are a cross-sectional tomograph, and this can be achieved by putting together a series of A scans. And the C scan is en face, and I'll show you these. This is going down through layers. The C scan is like you have a cake, and you take a slice off the top of the cake, take it away, and look at the next layer, and take another slice and look at it. That's the C. So with an OCT, you can get a cube of tissue. You go inside the eye with the OCT, you take a piece of, like a non-invasive biopsy of a cube of tissue, and you bring it out for the eye to look at. So there's the A scan, looking down. B scan is in that direction, and en face gives you the three-dimensional view. This is the first instrument that we had, the Stratus, and then 2 years ago we upgraded to the Cirrus, which gives better resolution. What's the difference? The Stratus is based on time domain, and the Cirrus is based on spectral domain, sometimes known as Fourier domain. In time domain, the mirror moves, and the sensor captures one image at a time, and the resolution is limited by time, because you can't keep the patient still for very long. You have to take one picture, then another, and then another. So there's time domain. So you take 3 pictures, for example. Whereas spectral domain, the mirror is fixed, and the sensor is able to capture multiple images, giving higher resolution and quick capture time. Benefits, as I say, of the spectral domain: quick image capture. You don't need to be as skilled, although actually in my practice the optometrists do it, not the clinical assistants, because there does need to be some skill involved. Less chair time for the patient, it's quicker, and better analysis tools. We get higher resolution. With my OCT, we get a resolution down to 5 microns. A rod or cone is 2 or 3 microns. We just looked about 2 months ago at a different system, the Spectralis by Hard Strite, which gives a resolution of 2 microns. Now, what colour is this? When we look at it, what does it mean? Reflections from the retina are interpreted and colour-coded on the strength of the reflection. Warm colours, like red, are highly reflective and dense. For example, a druce. Cooler colours indicate less dense matter, for example, the inner nuclear layer. And black means space, which usually means fluid, serous fluid or a cystic space. So here is a healthy macula. And you can see the layers here. The retinal pigment epithelium is in red. Here, there's the fovea. You can see the inner limiting membrane here. Just sometimes it's a little bit more red because it's quite reflective. And there's the green here, which is the outer nuclear layer. And you can see some of the other striations here. This is the choroid, and this is a choroid blood vessel in cross-section running away from you. Black areas, fluidal space is shown as black. So here we have a detachment of the pigment epithelium from the choroid, a pigmentary epithelial detachment. And this is fluid. What are the clinical applications?